Imagine this. Your mother's specialist appointment is, like, finally booked.
Right.
You've been waiting, I don't know, 6 agonizing months for this one opening. And the treatment she desperately needs, it's fully approved by her insurance.
Which is a miracle in itself.
Exactly. The doctors are scrubbed in. They're waiting at the clinic. But her life-saving appointment is about to be canceled.
Yeah.
And she's about to be hit with this massive, unexpected, out-of-pocket bill. And it's all because of, like, a 15-mile stretch of asphalt between her front door and the hospital.
It's just wild.
It really is. So today, we are diving into a paradox that silently derails, millions of medical treatments every single year. You have the coverage for the cure, but you don't have the coverage for the ride to get there.
It is arguably the most invisible crisis in modern healthcare today.
Yeah.
We spend all our energy, worrying about the diagnosis, the deductibles, the surgical risks, and we just completely ignore the physical logistics of moving a fragile human body from a residential bed to a clinical setting.
Right.
And that blind spot, it just creates total chaos.
Total chaos, which is exactly our mission for today's deep dive. We're demystifying the surprisingly, almost shockingly complex world of medical transportation coverage.
It's a maze.
A total maze. Dealing with medical bureaucracy in this specific area doesn't just feel like reading a map. It feels like reading a map where half the roads literally vanish depending on, well, who is sitting in the driver's seat.
Absolutely.
And to guide us through this, we are relying on a truly comprehensive guide from SwiftAid Transport. It's titled Navigating Medical Transportation, Medicaid versus Medicare Benefits.
It's a great resource.
It really is. And I'll be honest, reading through the source material, I found myself getting genuinely angry on behalf of families who have to navigate this.
Oh, I get it. The friction between clinical care and logistical reality is, it's a choke point. It forces everyday people into impossible situations.
Yeah.
You assume that if a multi-$1,000 treatment is covered, the $50 ride to access that treatment must logically be covered too.
Right, because that just makes sense.
But that assumption leads to missed appointments, deteriorating health, and just incredible stress for families who are already stretched to their absolute limits.
I'm so guilty of making that exact assumption.
Most people are.
Yeah. But before we look at the vehicles themselves, the stretcher vans, the wheelchair lifts, the dispatchers, we have to look at the money.
Always follow the money.
Always. We have to understand the two massive towering systems that are supposedly paying for this care, the two big M's, Medicaid and Medicare.
Right.
And I fell right into the trap of thinking they're basically two sides of the same coin. They sound the same, they both deal with health, they're both government entities, so they must operate the same way, right?
So that is, without a doubt, the single most dangerous misconception you can have when you start planning care for a loved one. Oh yeah, the brain naturally lumps them together. But to truly understand why your mother might get a free ride to the doctor while, say, your neighbor has to pay out of pocket, you have to understand that these two programs were built on entirely different philosophical foundations.
Okay.
They do not share a brain. They do not share a goal. They are designed for completely different populations. They operate under vastly different rule books, and they view the very concept of a ride to the doctor through fundamentally opposing lenses.
Okay, let's unpack this. Break that philosophy down for me, because I clearly don't have a handle on it. Let's start with Medicaid. What is the actual bedrock of the Medicaid program?
Okay, so Medicaid is, at its absolute core, based on financial need and limited resources.
Right.
It is a safety net. It was designed from the ground up to help cover healthcare costs for people who simply do not have the financial means to cover it themselves.
Got it.
So we're talking about eligible low-income adults, children, pregnant individuals, older adults, people with profound disabilities, and individuals who require long-term care support.
Okay, that makes sense.
But here is the structural detail that changes everything for you, the listener. Medicaid is jointly funded by the federal government and the state governments, but it is administered exclusively by the state.
Wait, I'm stuck on something right there. If it's heavily funded by the federal government, shouldn't there be, like, a universal standard?
You would think so.
Yeah.
Yeah.
Why on earth does the federal government allow a system where someone in rural Texas gets completely different access to care than someone in downtown Manhattan?
Well, because of the political compromises made when the program was created back in the 1960s.
Oh, politics, of course.
Exactly. The federal government sets a very broad, very basic floor of rules, but they hand the operational keys over to the state capitals.
Okay.
The states get to decide the exact income thresholds for eligibility.
Yeah.
They get to design the specific benefit packages. And crucially for our deep dive today, the state gets to decide exactly how transportation is managed.
Wow.
They act like 50 different independent healthcare republics.
So if I'm trying to help my aunt in Ohio figure out her rides, and I live in California, my knowledge of the California system is basically useless to her.
Worse than useless, it might be actively misleading. The Medicaid reality is highly localized.
It almost feels like Medicare is the federal highway system.
Oh, that's a good way to look at it.
Yeah, like if you drive on an interstate, the signs look the same in Florida as they do in Washington state. The speed limits follow a recognizable logic. The exits are numbered sequentially. But Medicaid is like local zoning laws.
Yes.
The minute you cross a county or state line, the rules on what you can build, or in this case, what kind of ride you can get, completely change.
That captures the structural divide perfectly. Now let's look at your federal highway, Medicare.
Okay.
Medicare is not a safety net based on poverty. Medicare is a federal health insurance program primarily based on age, specifically people who are 65 and older.
Right, the 65 milestone.
Exactly. It is also tied to your work history, meaning you or your spouse paid Medicare taxes into the system while you were working.
So income is totally irrelevant. You could be like a billionaire tech CEO, and the day you turn 65, you're enrolling in Medicare alongside a retired school teacher who is living on a fixed income.
That is the universal baseline of Medicare, age and work history.
Okay.
Now, there are a few very specific exceptions where younger people can get Medicare. It covers certain younger people with specific disabilities.
Right.
And it has highly unique carve-outs for individuals with very specific conditions, namely end-stage renal disease, which is ESRD, and amyotrophic lateral sclerosis, or ALS.
Hold on, I need to detour for a second because that is fascinating.
It really is.
Why just those two diseases? Out of all the catastrophic illnesses a younger person could get, cancer, heart failure, multiple sclerosis, why does the federal government specifically single out kidney failure and ALS for universal Medicare coverage, regardless of age?
It is a brilliant piece of medical history that actually perfectly illustrates how government policy is made.
Do tell.
Back in the early 1970s, dialysis treatment was brand new. It was a literal miracle. I mean, people who would have died from kidney failure could suddenly be kept alive.
Right.
But there weren't enough machines, and the treatment was astronomically expensive. Hospitals actually set up these terrifying God committees.
Wait, God committees?
Yes, panels of doctors and community members who had to look at a list of patients and vote on who got the dialysis and lived and who was denied and died.
That is horrifying.
Yeah.
A literal death panel just based on equipment shortages and money.
It was a moral crisis. The public outcry was massive. So in 1972, Congress passed a specific amendment to the Social Security Act that essentially said, if you have end-stage renal disease, Medicare will cover your dialysis and kidney transplants, period.
Wow.
Regardless of your age. It was a massive, unprecedented intervention.
And what about ALS?
ALS was added much later, in 2000, because the disease progresses so rapidly that forcing patients to wait through standard disability qualification periods was seen as unnecessarily cruel.
That completely changes how I view those acronyms. It's not just medical jargon. It's the result of massive ethical battles.
Exactly.
But even with those carve-outs, Medicare itself isn't just one simple program. You hear people talk about parts. I feel like I need a decoder ring just to get through the alphabet.
The complexity is staggering. Original Medicare is divided into two main pieces.
Okay, Part A and B.
Right. You have Medicare Part A, which generally covers hospital insurance. Think of it as the room and board of healthcare inpatient care, skilled nursing facilities, hospice.
Got it.
Then you have Medicare Part B, which is your medical insurance. That pays the doctors. It covers outpatient visits, preventive services, medical equipment, and, as we will discuss heavily, very specific ambulance services.
And then there's Part C and Part D. I know Part D is prescription drugs, which seems pretty straightforward.
Yes, D for drugs.
But Part C always sounds like a marketing term. Medicare Advantage. What is the advantage?
Part C is the wild card of the entire system.
The wild card.
Medicare Advantage plans are offered by private, for-profit insurance companies that have been approved by Medicare.
Private companies.
Right. If you sign up for Part C, you are taking your federal Medicare entitlement and handing it over to a private company. That private company is legally required to cover everything that Part A and Part B cover.
Okay, so the baseline is the same.
Yes. But because they are trying to win your business in a highly competitive market, they often bundle in extra benefits that original Medicare refuses to touch. Dental care, vision, hearing aids,
And transportation.
and transportation.
Ah,
But we will dive into the heavy caveats of that shortly. The core takeaway right now is that the architectural differences between Medicaid and Medicare are the absolute genesis of all the confusion you feel.
yeah, I can see that now.
You have one system based on local needs and low-income support, acting as a safety net. You have another system based on a federal age entitlement, acting as a clinical insurer. They naturally approach the problem of how do we get the patient to the building from entirely different universes, and you, the patient or the exhausted caregiver, are standing in the middle of these two giant bureaucracies just trying to hail a ride.
That paints a really vivid, somewhat terrifying picture of the bureaucracy. So we know who is writing the checks or refusing to write them. Let's look at what exactly we are trying to buy with those checks.
Okay.
Because we keep throwing around the word transportation. But the source material from SwiftAid Transport is incredibly specific. They don't call it a ride. They use the acronym NEMT,
Yes.
non-emergency medical transportation.
Sure.
What is that, and honestly, what is it not?
NEMT is the invisible bridge holding the healthcare system together. It stands for non-emergency medical transportation.
Right.
It is used for trips to highly necessary but non-emergent medical destinations. We are talking about taking a patient to physical therapy, to rehabilitation centers, to behavioral health clinics, to get specialized imaging like MRIs, to specialist consultations, and for hospital discharges.
Okay, so just to draw a hard line here, it is definitively not an ambulance screaming down the street with its sirens blaring, running red lights.
Correct. There is no active life or death bleeding out emergency happening in the back of an NEMT vehicle.
Yes.
The patient is stable.
Right.
But, and this is where so many families make a critical, sometimes tragic error, it is also absolutely not a standard taxi, and it is not a random rideshare app you tap on your phone.
You know, you are probably screaming at your device right now asking why.
Oh, people ask this every day.
If it's not an emergency, why can't I just call a regular rideshare for my grandmother? I mean, I can get a car to my house in 4 minutes for $12. Why doesn't that work for a medical appointment?
Because you are entirely ignoring the physical reality of the passenger. The limitations of a standard rideshare become glaringly, dangerously obvious when you actually look at the vulnerability of a medical patient.
Break that down for me.
Let's create a scenario. Let's look at Margaret. Margaret is 78 years old. She has ESRD, so she is on Medicare, and she just finished a 4-hour dialysis treatment at a clinic.
Walk me through that mechanism. What does a body actually feel like after 4 hours of dialysis? Because I think a lot of us just picture someone sitting in a chair reading a magazine.
The physical toll is violent, even if it looks peaceful from the outside.
Violent, really?
Yes. Dialysis is artificially doing the job of the kidneys. The machine pulls your blood out of your body, runs it through a filter to remove toxins and excess fluid, and pumps it back in.
Oh, wow.
Doing that over 4 hours drastically shifts the fluid balance in the human body. Margaret's blood pressure might suddenly bottom out. She is likely experiencing profound bone-deep fatigue.
That sounds awful.
It is. Her electrolytes are shifting, which can cause severe muscle cramping. She might be dizzy, nauseous, or completely physically unsteady on her feet.
Okay, wow. So she is not just tired. She is medically depleted.
Highly depleted. Now, imagine Margaret stepping out of the clinic and trying to navigate a standard rideshare.
Okay.
The driver pulls up across a busy 4-lane street because there's no immediate parking spot. Margaret has to somehow walk across that street, step off a curb, which requires balance she doesn't have right now, and fold her stiff, aching body into the low back seat of a standard sedan.
That sounds like a recipe for disaster.
It is. The driver up front has zero medical training. They have zero background in safe patient transfer techniques. Their only mandate, driven by an algorithm, is to get Margaret from point A to point B as fast as the GPS allowed so they can pick up their next fare.
Putting Margaret in a random sedan under those conditions sounds like an absolute guarantee for a fall in the parking lot or a medical crisis right there in the back seat where the driver wouldn't even know what to do.
It happens constantly, and that is exactly why NEMT is a specialized, distinct service. Professional NEMT involves far more than just 4 wheels and an engine.
So what does it involve?
It involves deep driver assistance. A certified NEMT driver does not just sit in the front seat staring at their phone. They provide door-to-door or frequently room-to-room
Oh,
assistance.
so they actually go inside.
Yes, they are physically trained to safely help a fragile person stand up out of their armchair at home, guide them to the vehicle, and secure them.
And the vehicles themselves are different, right? Because the SwiftAid Transport Guide spends a lot of time talking about the fleet.
Yes, it involves highly specialized, heavily regulated physical equipment. We are talking about wheelchair-accessible vehicles with hydraulic lifts that can safely hoist hundreds of pounds.
Wow.
We are talking about stretcher transportation for patients who are medically stable but physically cannot sit upright in a chair due to spinal issues or severe weakness.
Right.
It involves specific appointment timing to ensure a patient isn't left sitting in a cold waiting room for 3 hours after their chemotherapy ends.
So it's logistics executed with a clinical mindset.
Yeah.
You cannot separate the physical vulnerability of the patient from the vehicle they are traveling in. A ride isn't just a ride when the passenger's sick.
Exactly.
Mhm.
NEMT is a mobile extension of the care environment. It requires a level of communication and passenger-centered care that a standard taxi simply is not built, trained, or insured to provide.
All right, so we understand the vital nature of the NEMT vehicles, and we deeply understand the intense vulnerability of the patients using them. Now, let's put the system to the test.
Let's do it.
How does Medicaid, our state-run, needs-based zoning law program, handle these highly specialized NEMT rides?
This is where the story actually gets optimistic.
Oh, good. I need some optimism.
Medicaid is, in many ways, the hero of the NEMT landscape.
Okay.
In the vast majority of cases, Medicaid absolutely does cover non-emergency medical transportation.
Yeah.
In fact, if you work in the healthcare industry, Medicaid is the program most universally associated with making these rides happen.
That's a huge relief. So if my mom is on Medicaid, we can just breathe easy. The state handles it.
Broadly, yes, but let's look at the philosophy behind why they handle it because it dictates how you access it.
Okay, sure.
The federal branch of Medicaid, the Centers for Medicare and Medicaid Services,
All right.
or CMS, explicitly recognizes a foundational truth. Transportation has a direct, measurable impact on health outcomes.
Right.
CMS actually requires the states to ensure necessary transportation for Medicaid enrollees.
I love the logic there.
Yeah.
Medicaid is looking at the entire economic chessboard.
Yes, exactly.
They're saying, look, we, the taxpayers, are paying tens of thousands of dollars for this dialysis machine. We are paying the nephrologist's salary. We are paying for the clinic space. But if Margaret doesn't have a car and she physically cannot walk to a bus stop, our massive investment in her clinical care is totally wasted. We are throwing money away if she can't get to the building.
It is a stunningly rare example of holistic thinking in government healthcare.
It really is.
Medicaid views the ride as an integral, non-severable part of the actual medical treatment. The ride is part of the cure.
I love that.
However, and this is where families hit a brick wall, because this is a massive taxpayer-funded government bureaucracy, it is absolutely not a blank check.
Of course not.
You cannot just call up SwiftAid Transport on a Tuesday, book a premium wheelchair van, and casually mail the invoice to the state capitol.
Right. There are always strings.
Okay.
If the government is paying, you are going to be filling out forms. What is the gauntlet of requirements a patient has to survive to get this free ride?
The requirements are incredibly strict, designed to squeeze out any possibility of fraud or misuse.
Okay, hit me.
First, the passenger must have active Medicaid eligibility on the exact day of the ride, not pending eligibility, not last month's eligibility, today's.
Wow. Okay.
Second, the destination must be a strictly covered medical service. You cannot use a Medicaid NEMT van to go to the grocery store, even if your doctor wrote you a prescription to eat healthier food.
Oh, interesting.
You can't use it to go to the pharmacy to pick up pills unless it's bundled with a doctor's visit.
That makes sense. It's medical transit, not a personal chauffeur. What else?
Third, there must be documented proof of medical or transportation need. Why do you need a wheelchair van instead of a bus pass? Your doctor has to justify it.
Okay.
Fourth, and this is the absolute biggest hurdle, there must be no reasonable alternative transportation available.
Define reasonable alternative, because I feel like a government bureaucrat's definition of reasonable tart might differ from a stressed daughter's definition.
Oh, differs wildly. If you have a working car parked in your driveway, Medicaid expects you to drive it.
Even if I'm sick?
Well, if your spouse is healthy and has a driver's license, Medicaid expects them to drive you.
Got it.
If you live a block away from a bus stop and your doctor says you are physically capable of walking a block, Medicaid will mail you a bus token, not send a van.
A bus token. Wow.
Yes, you have to prove that your social and mechanical safety net has completely failed before the state steps in. And finally, there are strict advanced scheduling requirements. You usually cannot book a ride for tomorrow. You need to give them 72 hours or sometimes a week's notice.
Okay, let me unpack this. It's like having a VIP pass to an exclusive concert.
Okay.
The venue will actually send a private, specialized shuttle to pick you up at your front door, which is amazing, but only if you book it weeks in advance through their highly specific travel agent, and you have to legally prove that your own car's engine has exploded.
That analogy is painfully accurate. And speaking of that travel agent, let's look at how the states actually manage this, because they don't do it themselves.
Oh, really?
No. The SwiftAid transport source material gives us a perfect real-world example. In New York, the state doesn't want to be in the business of answering phones and dispatching vans, so they hire a broker. In New York, Medicaid transportation is heavily coordinated through an entity called MAS, which stands for Medical Answering Services. MAS acts as a transportation management organization.
So if I'm the patient, I don't call the driver. I don't call SwiftAid directly. I call the broker.
Correct. The broker is the absolute gatekeeper of your mobility. You, the patient or the caregiver, have to interact entirely with MAS. The ride has to be requested through their portal or phone line. It must be approved by their staff. It is then assigned to a transportation company by their algorithms and documented through their specific software system.
Why did New York implement a broker like MAS in the first place? It seems like it just adds a massive layer of friction.
Because historically, Medicaid was bleeding hundreds of millions of dollars to NEMT fraud.
Oh, wow.
Oh, yeah. In the old days, a shady clinic and a shady van company could team up, drive a patient in circles, and bill the state for services that were never rendered. Or they'd bill for a stretcher van when the patient just walked out to a normal car.
That is awful.
It was a huge problem. The broker acts as an investigative firewall. They aren't just taking reservations. They are auditing your clinical need. They verify your eligibility in real time. They call the doctor's office to verify the appointment actually exists.
Okay, so they're doing a lot of behind-the-scenes work.
Exactly. They determine the appropriate level of service to ensure the state isn't paying for a $100 wheelchair lift when you could safely sit in a $20 sedan.
So the broker system stops fraud, which protects the taxpayer.
Yes.
But it requires the patient, who is already sick and tired, to be highly organized, incredibly proactive, and willing to fight through phone trees and authorization forms.
Exactly. It saves money, but it exports the logistical labor onto the most vulnerable people in the system.
Right.
But at the end of the day, Medicaid steps up. If you jump through the hoops, the ride is there. Now let's contrast that with the program that most people over 65 rely on, the Universal Federal Highway, Original Medicare.
This is the part of the deep dive that legitimately shocked me.
Prepare yourself.
This is the source of so many tears, so much frustration, and so much financial panic for families, because the reality is brutal. Original Medicare, meaning Part A and Part B, usually does not cover routine non-emergency medical transportation, period.
It is the harshest reality check in the American healthcare system.
Let's pause on that for a second because it is so incredibly counterintuitive.
I know.
You are telling me that an 80-year-old man who has paid taxes into the Medicare system his entire working life,
Right.
who has a fully Medicare-covered, highly expensive knee replacement surgery, and who has a fully Medicare-covered physical therapy appointment to rehab that new knee,
Yes.
Medicare will look at him and refuse to pay for the van to get him to that physical therapy appointment.
In the vast, overwhelming majority of routine cases, yes, they will completely deny the claim.
How does that make any sense?
Yeah.
Medicaid just proved to us that if you don't fund the ride, you waste the treatment. Why does Medicare, the premier healthcare program in the country, ignore that logic?
Well, to understand why, you have to look at the historical boundaries Medicare drew around the concept of healthcare when it was created in 1965.
Okay, take me back to 1965.
Medicare was designed based on an acute care, hospital-centric model. Think about medicine in the 1960s. If you were really sick, you went to the hospital and stayed there for weeks. Outpatient physical therapy or complex daily infusions weren't really a massive part of the landscape back then.
Right.
The philosophy baked into the law was, we will pay for the clinical intervention, We will pay for the brilliant surgeon. We will pay for the hospital bed. We will pay for the highly trained nurses.
Okay.
But we assume that the social fabric of the patient's life, their spouse, their children, their church, their community, will figure out the basic logistics of getting the body to the building.
Medicare is basically saying, we handle the medicine, you handle the driveway.
That is precisely the boundary line. Medicare draws a hard, unforgiving line between clinical intervention and logistical support.
Wow.
They will only pay for transportation if your life is actively, immediately in danger in that driveway. Medicare Part B covers ground ambulance transportation only when traveling in any other type of vehicle could actively endanger a person's health.
So like a heart attack.
Yes. If you are having a massive myocardial infarction, a heart attack, Medicare covers the ambulance. If you have been in a severe traumatic car accident, Medicare covers the ambulance.
What if it's not a 911 lights and sirens emergency? What if I'm just bedbound, I can't sit up, and I have to go get a specialized scan? Does original Medicare cover anything then?
There is a very, very narrow exception where original Medicare might cover limited, medically necessary, non-emergency ambulance transportation.
Oh, there is.
Yes, but the burden of proof is astronomical. It requires a strict, advanced written order from a doctor stating that an ambulance is the only safe way to move the patient and that any other form of transit would be medically detrimental.
That sounds like a nightmare to get approved.
It is. We are talking about heavily restricted, highly scrutinized, easily denied situations. If you just need a standard wheelchair van to go to the eye doctor or the dialysis clinic, original Medicare is going to deny that claim flat out.
So if Medicaid is the VIP concert shuttle with a million rules, original Medicare is essentially the bouncer at the door of the emergency room. It's exactly.
If you are actively bleeding out, they pull you inside and cover the cost. If you just need a hand walking up the steps for a routine checkup, they stare at you blankly and tell you to figure it out yourself.
It leaves families entirely stranded. And this is exactly why the guide from SwiftAid Transport emphasizes this specific point so heavily.
Yeah, they really hammered in.
They have to. The number one misunderstanding their dispatchers encounter every single day is a family calling up, frantic, saying, my dad is being discharged from the hospital. He has Medicare, so the ride home is covered, right? Send the van.
Oh, no.
And the dispatcher has to be the one to deliver the crushing news that, no, original Medicare is not going to pay for this, and you need a credit card.
Okay, so original Medicare leaves a massive gaping hole in the system. But earlier, we talked about the alphabet soup. We talked about Part C Medicare Advantage, the private wild card.
Right.
Does that offer any hope for these stranded families?
It does offer hope, but it introduces an entirely new, incredibly opaque layer of complexity.
Of course it does. Medicare Advantage, or Part C as we discussed, is offered by private for-profit insurance companies, you know, the big names you see on TV commercials,
Right.
to attract seniors to sign up for their specific private plan. Instead of staying with the government's original Medicare, these companies have to offer sweeteners. And one of the biggest sweeteners they use is NEMT transportation benefits.
I'm naturally cynical, so I have to ask, why would a massive, profit-driven private insurance company voluntarily offer to pay for expensive van rides when the federal government absolutely refuses to?
It's a great question.
Aren't private companies notoriously obsessed with their bottom line? Why are they suddenly so generous?
Because it is entirely about their bottom line. It makes perfect, ruthless financial sense.
Really?
Remember the structure of an Advantage plan. The federal government pays that private company a flat, set amount of money per year to manage all of your care. The private company is now on the hook for the total cost of your medical bills. Let's go back to Margaret and her dialysis. If Margaret has original Medicare and she misses 3 dialysis appointments because she can't get a ride, original Medicare doesn't care about the ride. But when her kidneys fail further, she crashes, she calls 911, and she gets admitted to the intensive care unit.
Right.
Original Medicare pays the $50,000 ICU bill.
Oh, I see the matrix now.
Yes.
Yeah.
If Margaret is on a Medicare Advantage plan and she crashes and goes to the ICU, the private company has to pay that $50,000 bill out of their own pocket. Their profit margin is destroyed.
Wow.
So for the private insurer, paying a transport company $75 for a wheelchair van ride 3 times a week is a massive, incredibly cheap bargain.
It's pure return on investment. Preventative care access saves them exponential money on catastrophic emergency interventions later. It's cheaper to buy the van ride than to buy the ICU bed.
Absolutely. So many Advantage plans enthusiastically offer NEMT, and this is a massive, but it is a complete wild card. The benefits are not universal.
Yeah, what's the catch?
They are entirely dictated by the specific private contract you sign with that specific company in your specific county.
Meaning, I can't just assume I have free rides just because my neighbor, who also has an Advantage plan, gets free rides.
Not at all. It's like buying a car where the steering wheel and the engine are standard. That's the Part A and Part B clinical care that every Advantage plan legally must cover.
Right.
But the tires, the radio, the heated seats, those are a maybe depending entirely on which specific dealership you bought it from and which specific trim package you selected during open enrollment.
So if I do happen to have an Advantage plan with the transportation trim package, what are the fine print limitations I'm going to hit? Am I good to go for the whole year?
Almost certainly not. The SwiftAid Transport Guide outlines the common limitations of Advantage plans, and they are designed to cap the insurer's liability.
Makes sense.
First, you usually have a hard set number of rides per year. Maybe your plan covers 12 round trips. Maybe it covers 24 one-way trips.
That's a lot.
It's not. If you have a stroke and have to go to physical therapy twice a week for 3 months, you will burn through your entire annual allotment before spring even starts.
What happens, say?
You pay out of pocket. Second, there are severe distance restrictions. The plan might state they only cover trips within 15 miles of your primary residence.
Wow.
If you get a rare cancer and the best specialist in the state is 30 miles away, you are out of luck. The plan won't take you there.
Do they also control where I can go within that 15 miles?
Completely. They have approved network-only destinations. They might cover a ride to an in-network pharmacy, but they will absolutely deny a ride to a holistic wellness clinic or an out-of-network dentist.
It's so restricted.
It is. You also have to follow their strict advanced scheduling rules, which usually require 48 to 72 hours notice. And critically, you are usually restricted to using their specific plan-approved, contracted transportation vendors.
So I can't pick the company.
Nope. You can't just look up the company with the best safety ratings and local reviews and call them. You have to use whoever the insurance company signed a cheap contract with.
So even if you have the Advantage, you are still navigating a minefield of fine print, quotas, and network restrictions.
Yes, exactly.
Which brings us to a group of people who, I imagine, have it the worst. The source material talks about the dual eligible patient.
Oh, the dual eligible.
That sounds like a premier status, like a platinum credit card. What does dual eligible actually mean?
A dual eligible person is a patient who qualifies for both Medicaid and Medicare at the exact same time.
Okay.
Think back to our foundation. They qualify for Medicare because they hit age 65 or they have a severe disability, and they simultaneously qualify for Medicaid because their income and resources are so low that they meet the state's poverty threshold.
Okay, my logical brain says this person has hit the healthcare jackpot.
You would think.
Right. They have the universal federal baseline of Medicare,
Yeah.
and they have the state-run safety net of Medicaid to catch everything else. They must have gold-plated, stress-free transportation coverage, right?
You would think so, but the reality is an exhausting, soul-crushing, bureaucratic dance.
Really?
Being dual eligible is like having 2 entirely different sets of instruction manuals to defuse a bomb, written in 2 different languages. Because when a patient has both programs, the 2 massive bureaucracies have to fight over who is primary, meaning who pays first, and who is secondary, and their rules constantly clash.
Walk me through that defusal process. Let's say our dual-eligible patient needs a wheelchair van to get to a routine neurologist appointment on Tuesday. What happens?
Okay, the patient, or more likely their incredibly stressed daughter who is trying to manage their care on her 30-minute lunch break, calls the Medicaid broker to book the ride.
Right.
The Medicaid broker looks at the file and says, wait, your dad has Medicare. Medicare is the primary insurer. We, Medicaid, are the payer of last resort. We won't pay for this until you prove Medicare won't pay for it.
But we just established 10 minutes ago that original Medicare basically never pays for routine rides. The broker knows that.
Of course the broker knows that. Everyone knows that.
That's maddening.
It is. But the bureaucracy demands a paper trail. So Medicaid demands an official, formal denial of the claim from Medicare before they will authorize the trip.
You're kidding?
I'm not. So the daughter has to try and submit a claim to Medicare, wait for the inevitable denial letter, take that denial letter, submit it back to the Medicaid broker, and then try to book the van.
And meanwhile, the clock is ticking, and Tuesday is getting closer.
Exactly. The daughter is caught in a ping-pong match between a federal agency and a state contractor. Having both programs doesn't magically dissolve the bureaucracy. In many ways, it doubles the paperwork burden.
So what happens when the bomb goes off? What happens when all of these convoluted systems fail?
The safety net kicks in, or rather, the lack of one.
It's Thursday afternoon. The critical appointment is Friday morning. Medicaid denied the trip because the paperwork was wrong. Original Medicare is useless because it's not an emergency. The Advantage plan says you used your last ride in July, but the patient simply must get to the doctor. What is the final safety net?
The final safety net is the one that exists outside the government entirely. It's what the industry calls the private pay option.
Private pay, meaning exactly what it sounds like. You open your own physical wallet.
Yes. Private pay means the passenger, their family, their caregiver, or sometimes the healthcare facility itself, pulls out a credit card and pays directly out of pocket for the NEMT ride.
Now, I want to clarify something here. I think when people hear the phrase private pay in relation to healthcare, they immediately picture wealthy families hiring luxury black car town services to take them to boutique medical spas.
Oh, sure.
But in reality, based on the absolute nightmare of a system we've just outlined, private pay isn't a luxury for the rich, is it?
Not at all. It is often a desperate last-ditch measure for regular middle-class and working-class families who are caught in government red tape and simply cannot afford to miss a critical medical appointment.
That is so sad.
It is. Private pay acts as the crucial load-bearing gap filler in a deeply fragmented system. Let's look at who is actually using it.
Okay.
It's used by the senior who doesn't qualify for Medicaid because their modest pension puts their income exactly $50 over the monthly limit.
$50. Wow.
Yep. It's used by the family whose Advantage plan just cut them off. But heavily, it is used by families who are just trying to buy back their own time and autonomy.
To explain that piece, the autonomy part. Because if I'm paying hundreds of dollars for a van, I want something better than just a ride.
Think about the Medicaid broker system we discussed, MAS in New York. Let's say your mother has a complex neurological issue. You have been waiting months to see the top specialist. Suddenly, the clinic calls you on Wednesday afternoon, they had a cancellation, and they can squeeze your mother in tomorrow morning at 9 a.m. If you rely on Medicaid, you have to say no to that life-saving appointment.
Because the broker requires 72 hours advance notice.
Precisely. The government bureaucracy simply moves too slowly for the rapid, unpredictable realities of modern medical scheduling.
Wow.
So if you want that appointment tomorrow, you have to bypass the system and pay out of pocket. It highlights a massive systemic trade-off. Families constantly have to weigh the financial cost of private pay against the emotional and temporal cost of waiting on the government.
It's essentially a ransom. You are paying to escape the friction.
In a way, yes.
Yeah.
Families will choose private pay simply because they want control. They don't want to wait in a vague 2-hour pickup window assigned by an anonymous state algorithm, wondering if the van will show up before the clinic closes.
Wow.
They want to call a reputable provider like SwiftAid Transport, speak directly to a human dispatcher, request a specific pickup time, and know with absolute ironclad certainty that a clean, safe, professionally staffed wheelchair van will be sitting in their driveway at precisely 8:30 a.m.
So it's buying peace of mind. It's buying reliability and dignity in a system that is otherwise completely rigid and dehumanizing. But it comes at a significant financial cost that many families just can't bear.
It does. It is not always the cheapest option. A stretcher transport across county lines can be incredibly expensive.
Right.
But when the alternative is missing a tumor removal surgery that took 6 months to schedule, or leaving a vulnerable senior stranded on the curb in the freezing rain, private pay provides a level of dependability that the insurance frameworks frequently fail to deliver.
Let's pan the camera back a bit. We've talked a lot about the isolated individual patient. We've focused on Margaret going to dialysis or the daughter pulling out her credit card.
Right.
But this issue doesn't exist in a vacuum inside someone's living room. The confusion and failure surrounding Medicaid, Medicare, and NEMT creates massive systemic ripples that crash into the entire community. Let's explore the real-world stakes for the people surrounding the patient.
The stakes are astronomical, and the damage radiates outward like a shockwave. Let's start with the immediate circle, the families and the caregivers.
Okay.
The SwiftAid Transport Guide stresses this point with incredible urgency. Misunderstanding these rules prevents families from acting proactively.
Because if you assume the system will handle it, You don't build a backup plan.
Exactly. If you blindly assume Medicare covers the ride home from the hospital, you don't budget for private pay, you don't call the Medicaid broker a week in advance, you don't coordinate with your siblings to take time off work.
And then it all falls apart.
And the result is a frantic, tearful, chaotic morning on the day of the appointment. That chaos leads to either a missed appointment, which physically harms the patient's health, or a massive, unexpected credit card charge that throws a working family's monthly budget into total disarray.
The source material actually lists out the questions that families absolutely must ask up front to protect themselves. It basically demands that caregivers become administrative interrogators. What do they need to be asking?
They need to ruthlessly interrogate both the insurance company and the medical facility.
Wow.
They like to ask, what exact insurance does the passenger have active today? Is it original Medicare or is it an Advantage plan?
Right, because those are totally different.
If it's an Advantage plan, what is the exact specific phone number for the transportation benefit line and how many miles are covered? What is the physical status of the passenger?
Like, are they ambulatory?
Yes. Are they ambulatory, meaning they can walk to a sedan? Or do they require a wheelchair lift? Do they require a stretcher? Does the specific ride type need prior authorization from a doctor?
That's so much to manage.
And crucially, who is actually legally responsible for scheduling the ride? Is it the family's job, the doctor's office's job, or the state broker's job?
That is a staggering mental load to drop on a family member who is probably already exhausted just from the physical and emotional toll of caring for their sick loved one.
It is entirely unfair. But in the current system, the alternative to taking on that load is disaster. Now, let's look at the other side of the equation. The massive healthcare facilities themselves.
Right, the hospitals.
Hospitals, the inpatient rehab centers, the major clinics. You might think they have this all figured out. But this transportation confusion is a daily, multi-million-dollar operational nightmare for them.
Walk me through that. How does the single misunderstood rule about a $50 van ride impact a billion-dollar hospital?
I call it the discharge domino effect.
Oh, I like that term.
Let's build out a highly realistic scenario. We have a 75-year-old patient in bed 4B on the medical surgical floor of a major city hospital. He has been treated for severe pneumonia for a week. He is finally medically cleared by his doctors to go home on a Tuesday at 11 a.m.
Okay, good news for him.
Now, the hospital desperately needs bed 4B empty because down on the first floor, the emergency room is packed to the gills. There is a patient sitting on a gurney in the ER hallway who desperately needs to be admitted to that specific bed upstairs so they can get proper care.
Okay, the pressure is immense. The hospital needs to flip that bed immediately to keep the system moving.
The pressure is crushing. Now, the hospital's discharge planner, usually a highly stressed, overworked social worker, looks at the patient's chart in bed 4B.
Right.
She sees he has original Medicare. She is new, or she is rushed, and she assumes, incorrectly, that because Medicare paid for the week of pneumonia treatment, they will just cover an NEMT van to take him home because he is a bit weak and needs a wheelchair lift to get up his front steps safely.
Oh no, I see where this is going.
She calls a local transport company and says, "Come pick up the patient in 4B. He's ready to go. Bill is Medicare."
And the transport dispatcher looks at the request and hits the brakes.
The transport company says absolutely not. Original Medicare doesn't cover hospital discharges for non-emergencies. We will not get paid for this trip. We cannot send a van unless a family member puts a credit card on file for private pay or you get an emergency Medicaid authorization.
Boom. The entire massive hospital machine grinds to a halt over one van.
It doesn't just halt, the dominoes start falling backward. The social worker now has to scramble. She calls the family. The son is at work an hour away and his car can't fit a wheelchair.
Right.
The family doesn't have $150 to drop on private pay today. So the patient in 4B is physically healed, fully ready to leave, but he is logistically trapped in the room.
That is insane.
Because he is trapped, he takes up that highly expensive inpatient bed for another 12 to 24 hours, while the social worker frantically tries to apply for emergency charity funds or find a cheaper solution.
Meanwhile, the guy downstairs in the emergency room.
The guy in the emergency room is still sitting on a hard gurney in a loud hallway, not getting the specialized care he needs.
Wow.
Because the ER is backed up with patients waiting for beds, the new ambulances arriving outside in the ambulance bay cannot physically offload their new patients. The paramedics have to stand against the wall monitoring their patients on the stretchers.
Oh my goodness.
Because those paramedics and ambulances are physically stuck at the hospital, they cannot return to their zones. which means they cannot respond to new 911 calls out in the community.
That is genuinely terrifying. A 911 response time across the city is delayed because a guy on the fourth floor doesn't have a ride home.
It is the invisible reality of healthcare logistics. And all of it, the ER backup, the delayed 911 response, the exhausted hospital staff, the literally thousands of dollars in wasted inpatient bed costs, all of it traces back directly to a simple misunderstanding of what Medicare will and will not pay for when it comes to a single van ride.
That is a staggering butterfly effect.
It is. Transportation planning is not a minor administrative afterthought. It is a critical load-bearing pillar of care coordination.
This entire conversation has been a massive reality check. And the source material tackles this head-on with some heavy myth-busting.
Yes.
I think this is vital because so much of this confusion stems from urban legends passed around waiting rooms and Facebook groups. Let's systematically destroy the biggest myths.
Let's do it.
Myth number 1, I have Medicare, so I'm fully covered. My transportation is handled.
Categorically false. As we have exhausted today, Original Medicare is a clinical insurer that draws a hard line at the driveway.
Right.
It focuses almost exclusively on medically necessary life or death emergency ambulances. It will pay for the surgeon, but it will absolutely not buy you a routine ride to see that surgeon.
Myth number 2. Okay, but I have Medicaid, and Medicaid covers every single ride anytime I need it.
False. Medicaid is conceptually generous, recognizing the link between access and health, but it is highly restrictive in practice.
Those strict requirements.
Exactly. The ride is inextricably tied to strictly covered medical services. It requires flawless daily eligibility, and it forces you to navigate a slow, heavily audited broker system where you have to legally prove you have zero other options. It is not an open tab for free rides.
Myth number 3. If I have a valid doctor-ordered medical appointment, the ride automatically has to be covered by someone. It's illegal for them to just leave me stranded.
That is entirely false, and it is the harshest truth of the American healthcare system. The existence of a desperate medical need does not guarantee the existence of logistical coverage.
Wow.
The universe does not owe you a ride just because you are sick. Coverage depends entirely on the specific, rigid rules of your specific payer, not the severity of your diagnosis.
And finally, myth number 4. Wheelchair transportation is a specialized medical service, so it is always covered as a medical device necessity.
False again. A passenger might desperately physically need a wheelchair-accessible vehicle with a hydraulic lift just to leave their house. But the financial coverage for that specific, much more expensive vehicle type still depends entirely on the payer's rules, their network limitations, and prior authorizations. Just because you medically require the lift does not mean the government or the Advantage plan will automatically write the check for it.
This has been a massive journey. We started with the illusion of the pristine X-ray. The idea that healthcare is a clean, binary, flawlessly engineered system where broken means you get fixed.
Yeah.
And we have plunged deep into the incredibly messy, fragmented, deeply human reality of how we actually move vulnerable bodies to the places where they can be healed. Let's try to synthesize this massive amount of information into something a family can actually use.
Absolutely. If you take away nothing else from this deep dive today, you need to internalize the fundamental identities of the systems governing your life.
Okay, summarize it for us.
Medicaid is your state-run, localized, needs-based safety net. It historically recognizes the value of transportation and generally covers NEMT, but it forces you to operate through a highly regulated, slow-moving broker system designed to prevent fraud.
Right.
Medicare is your universal federal highway. It is an age-based clinical entitlement that will pay for the hospital bed. But unless you are in a catastrophic emergency requiring an ambulance, it absolutely refuses to pay for the logistics of getting you to that bed.
And sitting on top of that, confusing everyone, we have Medicare Advantage.
The wild card.
Right, the private wild card that uses transportation as a marketing sweetener, but traps you in a web of fine print, distance limits, and annual caps. And for those navigating both programs, the dual eligibles, it's a constant, exhausting battle of determining who pays first while the clock ticks down to the appointment.
Exactly. And underlying all of this, acting as the ultimate pressure release safety net, is the private pay option.
The credit card.
Yes. It is the flexible, reliable, out-of-pocket backup that families are forced to rely on when the bureaucracy moves too slowly, or the rules simply refuse to bend to the reality of a patient's immediate, desperate need.
It is a staggering amount of complexity to process. But as the guide points out over and over, understanding this architecture up front is the only way to protect yourself, your aging parents, or your patients from missed care, cascading health failures, and massive financial shock.
Be proactive, always.
Absolutely. And I want to explicitly remind you, the listener, of the source of today's deep dive. We have been pulling all of these insights, all of these historical contexts, and all of these vital warnings from the incredibly comprehensive guide created by SwiftAid Transport.
They really know this space.
They do. If you are in the trenches navigating this right now, if you are that daughter trying to figure out how to get your father to dialysis tomorrow without going bankrupt, I highly encourage you to direct your attention to their resources. You can visit them at www.swiftaidtransport.com to learn more about safe, respectful, and critically dependable non-emergency medical transportation. They are the experts on the ground dealing with these brokers and these insurance denials, actually making these rides happen every single day.
The work providers like that do is critical because at the end of the day, medical transportation isn't really about diesel engines, hydraulic lifts, and dispatch software.
No, it's not.
It is fundamentally about human dignity. It is about ensuring that a highly vulnerable person doesn't feel entirely abandoned by society just because they don't have a working car in their driveway.
That is incredibly well said. And before we close this out, I want to leave you with something to chew on. We've spent this entire time talking about the rules, the regulations, the brokers, the money. But let's look at the ultimate philosophy of what we've discussed.
I have a final lingering question for you to ponder long after you finish listening.
Okay, let's hear it.
We spend billions upon billions of dollars in this country developing miracle drugs, cutting-edge surgical robotics, and life-saving miraculous treatments. But if a life-saving medical treatment exists inside a gleaming hospital building and a patient sitting in their living room has absolutely no logistical way to traverse the 15 miles to reach that building, does that healthcare actually exist for them?
Oh, wow.
How does the physical, geographical distance between your front door and your doctor's office fundamentally redefine what access to healthcare truly means in our society?
It makes you look at that map with the vanishing roads a whole lot differently, doesn't it?
Yeah.
The multi-million-dollar cure might be entirely real, but if the road to get there is closed, it's just a mirage. Thank you for joining us on this deep dive. Stay curious, stay informed, and we'll catch you next time as we unpack another hidden layer of the world around us.